This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. Welcome, everybody, to another episode of PHM from Pittsburgh. I am still your host, Dr. Tony Tarchichi. For those of you who are new, welcome. And if you're a regular, welcome back. We are continuing medical education podcast started 10 years ago this October, bringing you information on pediatric hospital medicine. We're coming to you as usual from UPMC Children's Hospital, Pittsburgh. I'm in the Paul C. Gaffney Division of Pediatric Hospital Medicine. Now, ladies and gentlemen, this is a first. You're listening to this. This sounds normal, I hope, to you, but I am on a phone. The power is out in our faculty pavilion because of construction. My computer has died, and our guests are being immensely patient with me. So this is part 2 in our 3-part ADHD series. For our first part, if you're keeping score, we went over some of the, I would call, background material that we learned in residency in medical school, where somewhere along the line for ADHD. And this part is more of a day in and day out kind of stuff I didn't learn. Let's put it this way. I didn't learn, but stuff that comes up when you're in practice or if you have a kid who has ADHD. Now, before we start, we need experts for this, and we're bringing in 2 experts for this. I'm going to introduce them both, and then we'll do our disclosures and get started. Our first expert was with us for part 1, Dr. Heather Joseph, so welcome back. Dr. Joseph is a board-certified child and adolescent psychiatrist and assistant professor of psychiatry and pediatrics at the University of Pittsburgh School of Medicine. Her research interests are in early detection of ADHD and development of preventative interventions for young children at risk or expectant parents with ADHD to improve outcomes for families. She's a founding member of the Early ADHD Consortium, an international collaboration of investigators working to advance research on the early ADHD phenotype and biological environmental mechanisms influencing the emergence of ADHD from the prenatal period through early childhood. She's published over 30 peer-reviewed articles on the topic, including a top-cited article of 2023 in the Journal of Child Psychology and Psychiatry. And she practices psychiatry as a member of the Consult and Liaison Service at UPMC Children's Hospital, Pittsburgh. And she's in the Children's and Perinatal Telephonic Psychiatric Consultation Tips program. So welcome back, Dr. Joseph. And we are bringing in another guest, not 1, but 2 this time. Our second guest is Dr. Tracy Kennedy. Dr. Kennedy is a clinical psychologist and assistant professor of psychiatry at the University of Pittsburgh. Her NIH-supported research program focuses on understanding ADHD in youth and young adults, how ADHD may pose risk for substance use and other impairments, and the development of novel, real-time interventions to help young people with ADHD. In her clinical practice, Dr. Kennedy provides evidence-based therapeutic and diagnostic assessment for adolescents and young adults with ADHD. She has over 15 years of experience working with young people with ADHD, trained and worked at the University of Michigan, Children's Hospital of Philadelphia, the Johns Hopkins Hospital, and University of Pittsburgh, so just all over the East Coast. Her research has been recognized by a Career Development Award from the NIH, an NIH Loan Repayment Award, a National Science Foundation Graduate Fellowship, and research awards from several professional organizations, including the American Professional Society for ADHD and Related Disorders. Her expertise in ADHD is evidenced by dozens of national and international talks, over 40 peer-reviewed publications, including findings from the landmark Multimodal Treatment of ADHD, or MTA study. She tries, outside of work, keeps up with her 2 kids, coaches middle school students, and teaches college students as an adjunct professor at Pitt. So, Doctors Kennedy and Joseph, thank you for joining us, and thank you for being so patient with my technical problems.
Thanks for having us.
No problem. Yeah, thanks for having us.
So because we're a continuing medical education podcast, we've got to do our disclosures. So I will go first, and then Tracy, I will kick it out to you. I have nothing to disclose.
And I also have nothing to disclose.
I have NIH funding and other grant funding, but none of it will influence what I talk about today. So I'll go ahead and say I'm a third non-disclosure, like no disclosures.
All right, so nothing pertinent we're talking about. So good. So just as a brief recap of what we talked about last time, very, very brief. We went over the prevalence in 3 to 17-year-olds, any right around somewhere between 2 and 12%, depending upon what you're looking at. Boys are more likely to have ADHD than girls. We talked about the hyperactivity, impulsivity, and inattention. We talked a bit about how girls are more likely to have inattentive type, which is perhaps one of the reasons why they get diagnosed less, and boys are more hyperactive and impulsive, and in a school setting that can be more disruptive. We talked a little about there's this polygenic component that we don't really know a ton about, and the twin studies where the heritability rate was 76%. We talked about exposures that can lead to it in pregnancy or illnesses early on, or certain genetic disorders, and how adverse childhood experiences can increase the chances of it. Talked about sleep apnea masquerading as it. We went through the DSM 5th edition diagnostic criteria. And so for now, I guess what triggered me to want to make this is there's just some aspects of ADHD that have come up that either in social media where parents will ask about it, or on the floor as a parent who has a child with ADHD will ask about it or chat about it. And I would love to talk about them a bit with both of you. And I guess the first one we could talk about on our list here is the hyperfocusedness, where people will talk about social media, especially those who have ADHD, if they're doing something they're interested in. And the classic example I've read about is people who really like a book, or if they're into like Dungeons and Dragons or something, they will get hyper focused on a topic that they're interested in, and hours can pass and they're doing it and they don't notice at all. It is, and I'll start with whomever wants to start talking about it. Is that a thing? Am I right about this?
I'll jump in first and Heather can correct me. So hyperfocus, I would
As
say,
a reminder,
is a thing.
free CME
It is
is
not
available, and it's courtesy of the University of
diagnostic
Pittsburgh.
criterion
Just click on the
or
link
a
under the podcast description
symptom
and follow
of
the instructions.
ADHD, technically,
Thank
which
you
is
to the
really
UPMC
interesting.
Children's Hospital
And
of
certainly
Pittsburgh,
not
and especially the
everybody with
Policy Gassing
ADHD
Division of
experiences
Pediatric
this
Hospital Medicine.
hyperfocus phenomenon. But yeah, Tony, like you said, we do find that although when a kid is sitting, listening to a teacher, their attention is all over the place, they can't concentrate, and then you sit them in front of a video game, and yes, hours will go by, and they literally, forgot to eat or use the bathroom. And so it's sort of this flow state.
As always,
thank you for listening.
Presents as a very variable thing with the distraction in low motivation contexts and hyper focus and super highly motivated contexts is what we tend to see.
Yeah, and I agree with everything Tracy said. And one thing I would add is that given the situations where the hyperfocus arises, so things that are enjoyable, things that are like the preference for the child, it certainly can come up as a conflict in the parent and the child, and make it the diagnosis a little bit challenging to present to parents and families when they say, well, this might be, the child just doesn't want to do their homework, or they just don't want to pay attention in school. So making it seem as though the child has the ability to attend, but is choosing not to. So I think that can be a source of conflict, or a source that, families may struggle with hearing about the diagnosis of ADHD.
That's the part that has been brought up. It's like they ask, and I don't know the answer to this. How can they turn it on for the book they love, or the video game they love, or whatever it is they love, and they cannot turn it on at all in school or in math or anything else? How do you answer that question?
Mm-hmm. Yeah, I mean, this might not be totally satisfactory, but in the theoretical models of ADHD, one of the components of what we think is going on in ADHD has to do with motivation. So, for example, what is rewarding to somebody with ADHD, what really, gets those neurotransmitters going, might be calibrated differently than for somebody without ADHD. And I kind of think of it more than being able to turn it on in certain situations, more like being able to turn it off. So being able to turn off all the distractions, that are grabbing our attention all the time, which is a lot easier when we are locked in and like motivated and being rewarded by something like a video game, but a lot harder to do in a context where we're not as rewarded or motivated to listen, for example, to what the teacher is saying. So maybe two sides of the same coin, but that's how I try to help parents understand it.
Tracy, I love how you said so. Not an ability to turn that power, let's call it a superpower, or whatever, on, but it's an ability to turn off everything else in the room, everything else, even in your body. So they don't
Sure.
pee, they don't eat, they don't drink. And once you kind of get them up, they're like, "Oh my god, I got to go to the bathroom," and all of this just
Exactly.
back on because everything else is now let back in.
And we see that, I know we're talking about kids, but we see that in, young adults, adolescents, college students. I'll talk to my college students who tell me, I literally forgot to eat today. Like that the whole entire day has gone by because I've been whatever, like hyper focused or locked in. And so we see that at other ages too.
Now, am I going too far to say because we talked about the neurotransmitter dysregulation in the frontal subcortical network, dopaminergic and serotonin receptors are involved, and those are typically reward type things, that this is kind of how this happens. Whatever they like is very rewarding. Those receptors get really activated, they can block everything else out.
Yeah, I think that is a great explanation, and certainly we don't have, all the fine details of how this works for everyone, but certainly when we're thinking about using stimulants and some of the other medications, targeting dopamine is one of the key factors. So I think that's a great theory or way to explain what might be happening.
This is great. So, for those of you listening, now this is not what we typically do in the podcast, but the reason we decided to do this, the little background is ADHD is so prevalent that I would like to understand these patients a little bit more, the day in and day out things they go through. I think it'll help me be able to take care of them as a hospitalist. So I'm hoping if you're listening, you agree, but we're going to keep on going either way. Feel free to turn this off or keep on listening. So now social interactions, what I have heard a lot about is ADHD makes social interactions more challenging, but what I've heard a lot of is exhausting.
Mm.
Is that true?
That one's hard because I feel like it can be both, right?
Yes.
So some people might have challenges engaging in and attending to social interactions, like staying focused in conversations or in groups. There might be more distraction. They might feel like they have to turn the energy on to stay engaged. So that could maybe be exhausting for them. But I think it's also true in the reverse, where if you have someone who's very hyperactive, maybe inattentive, maybe impulsive, it could be exhausting for the people around them. And that can contribute to social difficulties in both directions.
Yeah, I totally agree. And this is not scientific at all, Tony, so don't quote me on this. But what I hear a lot of anecdotally is this idea of like, I've got multiple channels going on in my brain at the same time, and I'm like aware of them and I'm sort of tuning between them. And some of those channels really get turned up when I'm in, a social interaction and there's lots of stuff going on. So although it can be energizing and be really stimulating, and there's good things about that, I can see how that can also be exhausting to sort of keep up with so many of different things going on at once.
Okay. I mean, it's helpful that you've both heard about this. So, because some of this is from families or social media, and I'm happy that this is a thing. Now, one of the things I have heard a lot of is in adolescence, ADHD becomes more challenging for parents to deal with adolescents with ADHD. And in one of those areas, it's just daily task of living kind of completion, specifically like showering, brushing teeth. Parents have told me that kids with ADHD in their adolescent years will blend one day into another to where they think they brushed their teeth. They're adamant, but they did it yesterday, not today. And it's hard for them to figure out, like, no, that was yesterday, not today. And the same thing with showering. Is it true like they can blend one day or task into another and think they've done it when they haven't? And how do you help them with that?
Well, I would say adolescence becomes harder regardless of ADHD or not, right? So then we have this exacerbating factor of ADHD. Yeah, what you're describing, Tony, makes me think of the working memory problems that we see in a lot of young people with ADHD. So, memory, there's a lot of different types of memory, but what we see often impaired in ADHD is working memory, which is sort of this like actively keeping something in mind as you go through your day and being able to manipulate it or do something with it. So, kind of that active going through your day and yeah, sort of blending. I feel like I just brushed my teeth, but that's getting all conflated with the other stuff that I've done during the day. So that might be part of what's going on there.
Yeah. And one thing that I was thinking about as you were saying this is that, when you have a young child, the parents do a lot of scaffolding of their day and their activities. And parents assume, like, this will get better. And the young adults, as they're transitioning to that age, will start to take on more independence and do things without my support. And so it may be that it's not really a change in adolescence, it's that their abilities are not matching the expectations of the parent for a child of that age. And so this may be a challenge that was always there, but now it's not meeting what maybe their siblings or other kids their age are able to do independently. And so I think really we still need to provide additional supports and scaffolding for these adolescents, maybe more than we would for kids without ADHD.
That's so great. I had a follow-up question written down, but I have a question based on your answers. And Tracy, I guess I'll start with you. How else do these working memory issues, in your experience, come up in adolescents and kids with ADHD?
Yeah, I think it comes up in tons of different ways. It can be just daily, you know, remembering things, misplacing things. I just had my keys on me. Like, where did I put them down? Really keeping that actively in mind. For adolescents and young adults in college, the idea of like sitting in a lecture and taking notes on what you are hearing or just heard, and then trying to keep your brain active and catching up to now the next thing that the professor's saying, that's a really hard skill. And we see those working memory difficulties impairing, the classroom based learning. So those are some key examples that come to mind.
So, Heather, you talked a little bit about the scaffolding as a younger child, and you expect them to get better. So then how do you, when they're in adolescence or even in college, how do you help them work through these issues as a parent, or how do physicians guide parents to help them work through these issues? What type of things would you recommend?
It's a great question, and Tracy may actually have more behavioral strategies, but I do think that this is an area where you're going to start thinking about how do you use a planner and an organizer and checklists and ways to help reduce the burden of constantly remembering, and just really having more of a structure in place to help make things more routine and reminders. But I'll pass it to Tracy in case she has something to add.
Totally. Yeah, totally agree. We talk a lot about like there not being one magic bullet system or behavior strategy, but finding a system that works for you and use it constantly, consistently to where you're hopefully building a habit and taking that extra thought or memory part out of it so that it really becomes habitual. When you're building those skills, there's a really nice treatment model for adolescents who have ADHD to work with their parents, and it uses a motivational interviewing approach. So what that means is it's not coming in and telling the parent, "Hey parent, like this is how you have to manage your adolescence ADHD symptoms." And it's not just coming in and saying, "Hey teen, like what do you want to do with your life? Let's make it happen." It's really finding the mutual goals and helping the teen figure out, "All right, well I want my parent off my back. So if I want that, how do I practice this new skill I'm learning to take care of it on my own so I get them off my back?" So I really like that. It's called the stand therapy approach.
The stand.
Yeah, I forget what it stands for. I'm sorry, I'd have to look it up. But it's by Margaret Sibley is the author of that treatment manual.
So then, Tracy, what would you tell the college student who said to you, I can't take notes and listen in a lecture hall? What do you have them do?
So we definitely see some accommodations in college be helpful for students with ADHD. So being able to get those notes, those lecture notes ahead of time. And what I tell students is like, even if you have to do this on your own, take some of the information out, just like one word, so that you're still actively listening, but it's just like one word that you have to fill in instead of the entire, picking out what the professor is saying. So that accommodation can be really helpful in that case.
Okay, that's very nice. Now, along the line, I think Heather put in our chat, STAND stands for Supporting Teens Autonomy Daily.
Perfect.
That's
Thanks,
great.
Heather.
Thank you, Heather. So along the lines of adolescence, let's stay on that vein. One of the things I have seen, read, and heard in specifically boys during puberty is this rage issue where just they'll be fine, 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 and then something tiny happens and they're just angry and yelling. And what we talked about in our preparation for this podcast is girls are different. Can you talk about if I'm right about the boys thing, and if there is a difference with the girls?
Yeah, great question. So the way I think of it, boys or girls, is sort of the umbrella issue of emotion regulation in general, or so impulsivity is a key symptom domain of ADHD, and we can be impulsive in our emotions too, and how quickly those emotions can change and kind of get out of hand. So we know that to be true. And what I think is probably happening is that, strong emotions may tend to look more like anger or this rage for boys who are going through puberty. And then for girls, maybe more likely to come out as sadness or anxiety, for example. But I really see it as that emotion dysregulation or impulsivity.
So then I guess the question would be, does your ADHD treatment, so your stimulants that we use, does it help with this, or is this kind of dysregulation there? And then if it's there, let's start with that. Does ADHD stimulant treatment help with it?
Yeah, I think it can help reduce the emotional lability, and it can also help them to just take a pause and kind of reflect on their emotions before reacting. So certainly treating with medications, I think, is important if this is a particularly a big problem for them. And then it also is important to consider things like cognitive behavioral therapy, where they can start to really tap into their emotions, understand them, and think about how they can change their thoughts and behaviors around their emotions and reactions.
Now, correct me if I'm wrong, cognitive behavioral therapy is focused on the patient themselves. For the families, or for when they ask us, what do we do specifically with the rage issues? What I've been asked, like, how do I talk to them when the smallest thing will make them angry? When they're at that angry state, how do I talk to them to kind of bring them down? Is there any recommendations at that point to kind of help redirect them or anything?
Yeah, this one's it's hard. I think it's going to be very specific to the family, the child, the situation. So I would say in general, as clinicians that work in behavioral health, we are, very in tune to wanting to do some verbal de-escalation. Sometimes people just need space. So if the parent and the child have had a conflict and the child is very upset, continuing to talk through what's happening might not be appropriate at that moment. It might be give some space and then let's regroup and try to understand what was happening. Why did they feel that way? So that's one thing I would recommend is maybe in the heat of the moment, you take a break as a parent. You take a moment, make sure your child's in a safe place, and you give yourself a moment to recollect your emotions and thoughts as well.
Yeah, I would just say, too, in addition to what Heather mentioned, that stand therapy, actually the very first steps in that therapy, working with parents and teens, is very basic communication strategies. So, kind of having a script and like a go to sort of neutral language that you practice with each other in the calm and easy moments so that you can sort of like default back to that language in those sort of high emotion moments.
Oh, that's helpful. Okay.
Yeah.
Now this stand therapy, because we now brought it up a couple times, is it a book? Do you need someone like you, Tracy, to help you walk through it?
Yeah.
If our physicians or even parents listening want to be involved in it, what do you need?
Yeah, so there's a treatment manual. It's a book by Margaret Sibley. I really don't have any disclosures, I promise. I just use the treatment and it's been helpful. There's been studies on it, so there's evidence base for it. I wouldn't say that it's easy for a parent just to pick up because it really requires a provider who is pretty skilled at using the core motivational interviewing techniques, which I know many physicians have had exposure to in different contexts, but it's the same general ideas with any presenting concern as those basic motivational interviewing stance. So, if you have a little bit of that, I think you could pick up the manual as a provider and be able to work some of it into a treatment you're doing.
One other thing I wanted to kind of mention about how do we address this, especially if it's reaching to the point of rage and every time something comes up, the adolescent is, kind of out of control with their emotions, is that it might be time to consider, is this just ADHD or is there also depression or anxiety that's contributing? Because that, that extreme and that persistence of emotion dysregulation does start to make me think about depression, for example.
Well, that was perfect. That was my next question for you, which is with ADHD, we've talked about some patients, and we'll try not to label them by sex because it can happen, I think, to anyone. Some patients have more sadness, more anxiety, perhaps more depression. Do you see an increase in those mental health issues with patients with ADHD?
Yes, we definitely do see a higher rate of those conditions than in the general population.
Yeah, and Tracy, one of the articles you sent around was looking at adolescents, young adults with ADHD compared to individuals without, and they were reporting rates as high as almost 80% for depression, anxiety, comorbid disorder. So it can be very high.
Quite high, yeah. And I would say really comorbidity with other mental health diagnoses is really the norm rather than the exception with ADHD.
Oh, that's helpful to know. So I almost expect it. Don't be surprised by it.
Exactly.
So then, along those lines, as a provider, whether you're a hospitalist or even an outpatient provider, once you start seeing it at that point, is it fair to say the right thing to do is refer to someone such as yourselves who can help with treatment
Yes.
as
I'd say
early as
so.
possible? Okay. Now, I have here prevention, presentation, and management of rejection sensitivity dysphoria. And I can't for the life of me remember why I put that there.
This is something that we're seeing pop up a lot, like in, I don't know if it's social media or popular media, and it's really just starting to gain traction in the research field is this idea of rejection sensitivity. And Heather, I don't know how much you've seen about it, but I think it's something that's come from sort of the general public or the popular media that now researchers are turning their eyes to and trying to figure out what empirical evidence there is for it. This idea of a heightened sensitivity to like rejection or social rejection in different ways.
Heather, anything you want to add to this?
Yeah, I have nothing to add. I think this is a future area. Maybe we'll come back when there's more research on it and share what we know.
Okay. All right. So this is something we'll keep an eye on, but for now, we'll see. I'm always skeptical of these things that come from social media and from the public because, again, rigorous research, et cetera, is important, which is why I brought you two on as experts. So this is great. Now, one of the areas I'd like to talk a little bit more about is ADHD and concomitant drug use, suicide, and alcohol. We know that there's increased prevalence. Can you fill us in a little more detail, whether it's why or how or what you've seen in your clinical practices?
Sure. Yeah. So in terms of substance use, We definitely see heightened rates of substance use in young people with ADHD. And what does that exactly look like? It tends to look like younger age of onset. So kids who are getting into substances 1 to 2 years earlier on average than their peers who are also experimenting. And then that itself sort of being a risk factor for progressing to greater substance use. We also tend to see the substance use around nicotine use, and that's shifting from smoking cigarettes more to vaping these days. And cannabis as well is higher among individuals with ADHD and on the rise. We do sometimes see higher rates of alcohol use, so like how much you're drinking, but more so than actual levels of use, we tend to see similar levels of use, but more problems among individuals with ADHD. So once you're getting into young adulthood, mid adulthood, greater problems and, consequences associated with that use. So that kind of covers the substance use realm.
Yeah.
When you say, when you say problems, Tracy, are
Yeah.
you meaning like, are you meaning a broad swath? So like car accidents with alcohol use, STDs or sexually transmitted infections with alcohol use,
Yes.
abuse, trauma, neglect, etc.
Yes. All of the above. Kind of the whole swath of potential consequences of use.
And
I think we're still learning more about like longer term health risks because ADHD, is fairly new in terms of like longitudinal investigation. So as these cohorts of individuals with ADHD age, we'll be able to understand more about that long term health outcomes.
that's wonderful. Heather, I interrupted you. I'm sorry with that. What were you going to say?
No, yeah, I was just going to clarify some of the things you were asking, but more so that, part of it might be that the core symptoms of ADHD make it hard to, put limits on how much you're going to drink or follow through on your plan to have a safe ride home. So there's just more impulsivity, less planning, less thoughtfulness around the substance use that can then lead to the problems in the moment when they're using the substance.
Now, what I'm about to ask you, it came up while you guys were talking now in my head, and it may be unanswerable, so feel free to say so. But is it that the impulsivity leads to the increased alcohol, tobacco, and suicidality, or is it that what we've talked about already, that the 80% or so, or just the high rate of concomitant mental health disorders, anxiety, depression, play a big role in that as well, or can we not parse that out?
Such a great question. I would say it's going to be multiple pathways, depending on the individual. We have evidence for all of those things you mentioned, and even potentially like genetic risk for both the impulsivity piece and, some of the other factors leading to substance use. So I think it depends on the individual.
Everyone's nodding in agreement. Great. This has been so helpful so far. This is really great. So the one thing I did skip over, this was my fault. In social media, you see a lot of comments that kids who have ADHD are less mature than their age-matched peers. Now, is that part of the emotional dysregulation you talked about? Is that a thing, or is that just individually dependent?
Yeah, I think in episode 1, we talked a little bit about brain development and seeing a maturation lag. Some of the studies are sort of saying 4 years of brain lag in the frontal cortex. And I think that that's probably what we're also seeing behaviorally is that this maturation is presenting in changes in their ability to engage, their ability to have executive functioning skills that would be on par with their same age matched peers.
Super helpful. Now, this one, we have a question on. We talked a lot about in the first episode about people diagnosing themselves due to social media and the amount that's happening, and we talked about how women for years were underdiagnosed because they those who were underdiagnosed likely had the inattentive type more. We're just less disruptive in class. Is there anything else along that line of self-diagnosis and social media that you all are seeing that we didn't talk about in episode 1?
There's a pretty recent study that was published where expert reviewers reviewed some number of hashtag ADHD TikTok posts. And I think there were a number of findings from that, but the key one that sticks in my mind was that about 50% of those posts were in line with our, evidence-based DSM understanding of ADHD, which that's 50%, which is
Honestly, higher
kind of
than I
good.
thought.
Right.
Yeah.
But that does mean that the other 50% is getting information out there that could be completely wrong or misleading. And it's hard for people just scrolling through their TikTok to know which one it is. So there's quite a mix out there. And it's not always easy to parse out the true from the false.
I love that. Sorry, that's great, Tracy. So I'm going to skip our IEP question in the interest of time, and because I really want to get to. We talked in episode 1 about what medications are helpful and why, and then besides medications, and Tracy, I know this is an area of expertise of yours. What helps kids or adolescents or young adults with ADHD in certain terms of treatment? Any of the yoga, meditation, exercise, mindfulness, even vitamins we're seeing. What do you help us with this?
Well, this isn't especially my area of research, but we are definitely seeing that, as I mentioned before, like behavioral non-medication strategies can be extremely helpful for young people with ADHD. There's a lot more research now looking into some of the exercise interventions, yoga, mindfulness, and I think we're trying to see if, there will be an evidence base that will build up for some of those complementary or alternative types of treatments.
And just to add that Kelly Beck, who will join you for the third one, really does focus a lot on mindfulness, and she's certified in mindfulness-based approaches through the UPMC Complementary and Alternative Medicine Clinic.
Okay, so more to come. So do you, in your practices, recommend these for patients? Or just in general, like anybody else, you'd recommend exercise, mindfulness? 'Cause it's good for all of us.
Pretty much, yeah. It's probably not going to hurt, and it could help, so.
We talked about, the last thing we had was ADHD and adolescent relationships. We talked about that a little bit already. In terms of, well, I don't know. I don't have any questions to ask about that besides what we talked about. So, I mean, that's really kind of all of it. This was great. This was such a nice kind of run through stuff we really don't learn a ton about in residency or medical school on ADHD and the daily grind, the daily kind of working with someone who has ADHD. Is there anything we didn't discuss? I'll start with you, Heather, and kick it out to you, Tracy, that you two wanted to make sure we talked about.
The only thing that we didn't discuss that Tracy, I'll actually let Tracy talk about it, but she was a co-author on a paper that looked at fluctuations in ADHD symptoms over time, and I think it would be really interesting to kind of hear her perspective on that because it may come up in clinical practice as well.
Yeah.
Yeah, that's a great point, Heather. For a long time, I think it was assumed that ADHD is this constant thing and it doesn't change. And while that might be true to some extent in that it is a neurodevelopmental disorder and most people are probably going to have some struggles for most of their life, we found in the MTA study that over years from childhood through to age 25, the most common course of symptoms wasn't just a straight line, it was ups and downs of symptoms to the point where there were times when somebody with ADHD no longer met criteria for ADHD. And then the next time, 2 years later, they were assessed, they did. And that really was the norm of symptom course. And then what I'm really interested in is looking at that on an even more acute time scale. So across the week or across the month. how are ADHD symptoms fluctuating to the point where they might be more impairing one day or week and not as much the next? And how can we predict and leverage those trends to help these young people?
Tracy, I did not know that. That is absolutely fantastic. Now, was that related at all to hormonal changes in terms of puberty or not, or just up and down randomly?
Oh, that's a great question. The study did try to look at some of the predictors of those fluctuations. And interestingly, we found that when folks were doing better, they also tended to have more what was called environmental demands. So they had more responsibilities, they were working, they had financial obligations more so. So it begs the question, when people are doing better in terms of their ADHD, are they able to take on more? Or do they kind of rise to the occasion when they have more of that responsibility? I don't think we really know why that's happening, but those were some of the predictors. As far as like hormonal changes, we did notice that those environmental demands tended to make more of a difference in the adolescent age group, but not that the fluctuations tended to happen more or less in that time period.
So downtime, lots of downtime in that study was not all that helpful for for people with ADHD.
That would be, the implication. Yes. And that's definitely clinically what we try to teach parents is create structure, create systems rather than kind of leaving it open.
Oh,
I found the article fascinating and the work, and there are some limitations of how you can interpret the findings because there's times where these data were collected across different years, and some of it might be that when things are good, they can do more, or when things are bad or like challenging in terms of symptoms, they do less, or they're not in school because they did poorly. So it's hard to know specifically which direction these things are going. But even just anecdotally in some of the interviews that I've done with parents with ADHD, it's really interesting to hear how people might self-select into jobs where they then excel, but they need to be able to like move around, for example. Like I've heard people say, I had a desk job and it was awful. And I was late to work often. I hated being there. I wasn't productive. And then I got a job in security where I can walk around the whole time and I'm like employee of the month. So there's a lot of differences that I think you can, if you leverage what is good for you, you may be more successful. And then you may also see these symptoms fluctuating over time based on the demands that are placed on you. So if you don't have to sit and pay attention to something, you might report there's no inattention. So for me, I think it's really fascinating. And I don't necessarily see it as episodes like we think of for depression, where you have depression and then you don't have depression. I really do think that the environment and the context is feeding into the severity of the symptoms at that time in their life.
That is so fascinating. This is really great. I have to tell you, this episode has blown me away in terms of beat my expectations significantly. I can't thank the two of you enough. This has been great.
Thank you so much.
Yeah, we appreciate it.
Any other ADHD stuff we have, I'm gonna get you on. So thank you all so much. And for those of you listening, stay tuned for episode 3 because we're going to do even more.
As a reminder, free CME is available and it's courtesy of the University of Pittsburgh. Just click on the link under the podcast description and follow the instructions. Thank you to the UPMC Children's Hospital of Pittsburgh and especially the Paul C. Gaffney Division of Pediatric Hospital Medicine.
Thank you again to our expert guests and special thanks to all of you who take the time to join us. We know that your time is valuable and we appreciate you sharing it with us.
Please feel free to email my dad at tony.tarchichi@chp.edu for any questions, comments, or podcast ideas.
As always, thank you for listening.